I want to take the time to hopefully share good news and try to end this session in a high note, because we have identified the problems, we have discussed what vulnerability is, we understand the disparities and the inequities that some of the populations that are disproportionately affected by HIV are experiencing, but in fact we are doing something. And we should learn from the experiences of what is working to replicate, to improve the services that we can have. So I decided to share a case presentation on the retention in antiretroviral therapy among incarcerated populations that are re-entering the communities here in Puerto Rico. And I have to say that putting together this presentation was also a good opportunity to look at all the work that we've done with incarcerated populations in Puerto Rico for almost 20 years now. So briefly, I would use this as an example and discuss the experience as a way of, bringing with a case of something that is working. I will expand the discussion that we already started on vulnerability in context, talking about prisoners and people living with HIV. We have already mentioned the burden of HIV in Puerto Rico, but Puerto Rico also have one of the highest prison population rates in the world. Right now we have nearly 10,000 people who are incarcerated. 98% of the people in prison are men, and it's estimated that nearly 7% of the overall prison populations have been diagnosed with HIV. Those living with HIV and with history of incarceration, we know that they are experiencing many needs. Sometimes they don't have an ID, they don't have where to go, a job. They might want to go back to school, but they don't have the resources to do that. With the work that we've done, we know that when we work with people who are re-entering the community or in the release plan process, they're not thinking about their health. They have other priorities. They're looking forward to see their families, going back to their communities, perhaps looking for a house. So going back to the discussion on social determinants of health is a great opportunity to deal with many factors that influence the health status of people being released from prison. But in context, we also have to understand how the colonial status of Puerto Rico is crucial in coming up with solutions. We don't have enough resources, and we don't have those resources not because we are not capable. We don't have the resources because we have policies that are imposed on us without our participation that impede the ability of our country to come up with solutions that can be locally tested, proven efficacious, but without the support of the structure that is supposed to support that kind of work. And also, I would not get in all the details here. I think we can agree that mass incarceration is a public health problem, it's a social problem, that we need to figure it out how to do better with our criminal justice system. But overall, the experience of incarceration increased or heightened the HIV vulnerability of the people that experience incarceration. So in Puerto Rico, we started identifying gaps in the continuity of care. Previously, this is a study that we started in 2010. And yes, that's almost 10 years ago. But the lovely story here is that we started publishing on correctional health care in Puerto Rico barely a decade ago. But since then, we identified the prevalence, and it was unfortunately very high. It was very high among women. Then we identified that we had gaps in care. People were taking almost 4 years in average from release from prison to be engaged in HIV care in their communities. That's a big problem, because you know what happened when people fall out of service. However, in other contexts with other resources, people were testing models to engage people who were re-entering the community. One of those models was the Transitional Care Coordination that was created in New York City, Rikers Island. And they created this model, again, I would not go into details, but basically was providing services to inmates before they'd been released from prison, started 6 months before, identifying those who were HIV positive, identifying their needs, what they needed, where they were returning to the community, and helping them navigating the system before being released, and having an appointment to an HIV clinic before they were released and re-entering their communities. And then following up with them and helping them to stay engaged in care. So that model worked. We had evidence in New York City So about 5 years ago, a collaboration started between the New York City Department of Health, our team at the University of Puerto Rico, and a community partner, One Stop Career Center of Puerto Rico. One Stop is an organization that for almost 20 years has been providing services to people that were leaving the correctional facilities in Puerto Rico. But they were not including health in the equation because it was not the priority of the people that they were serving. And the organization had very little capacity or knowledge on how to provide services. So the model that we use here was actually building capacity in an organization that was already addressing the main issues affecting people being released from prison to also help them navigating services. So here are details about the collaboration. I'm not going to get in all of them, but basically the organization worked with creating collaborations with community organizations. So Puerto Rico overall was covered with MOUs, so we could recruit participants or people living with HIV in the prison system to organizations in the community. And this is the story of success here. As part of the feasibility study, we recruited 80 participants. Most of them engaged in the transitional care coordination. Most of them actually engage in services in their community, and 94% of those who engage in services in their communities actually kept linkage to care. What are the good news with this is that we had people that stayed in HIV care. And extra good news is that, and we're still following some of these participants, we also reduced recidivism or reentry to the correctional facility. And those are really good news because we are providing with what the people actually needed, not only the health care, but access to housing, education, employment. This is a map that illustrates where the people were connected to service. And just looking at Camila's presentation, I realized that these bubbles overlap very much with the data that we have from NHBS with injection drug users. So people are returning to communities that we know are of increased risk for other behavioral factors that might increase vulnerability. But we are working with organizations that are there because we didn't create services in the community, the services were there already. And as we have mentioned before, Hurricane Maria also affected this project. Fortunately, One Stop had a very good response. They got resources mostly from non-governmental organizations to provide services to people who were at increased risk for being disengaged in care because they were not having access to basic elements like medication, housing, and food. So what we learned from this experience? First of all, that it's possible to retain patients in HIV care after incarceration. We did it with 94% of those who engage in the intervention. The consortium, the collaboration can be maintained and is crucial in order to continue providing the services. The MOUs started with the research project, but we kept the MOUs. So now the services are being run by the organization without the support of the research funding that was available to assess the feasibility of this intervention. And finally, that engaging patients during incarceration fosters relationships that endure after incarceration, and that also helps in reducing the negative impact of other social determinants of health. I want to thank all the participants, clinic, correctional facilities, the team here in Puerto Rico, and all the collaborators, and this project was funded by HRSA. Thank you.